name is Albert Aboseif. I am a fellow at Mayo Clinic. I completed my neurology residency at Cleveland Clinic, worked a lot at the Mellon Center there for MS. And then I came here for my clinical fellowship. So I did a clinical fellowship in autoimmune neurology in 2023, and then in 2024 I did the MS clinical fellowship. And this year I am one of the Applebaum Fellows, doing research primarily in multiple sclerosis and in early asymptomatic forms of multiple sclerosis. But I do have an interest in MOG as well. I worked with Dr. Flanagan on a project looking at meningitis in MOG as a phenotype of MOG that maybe is under-recognized among patients. And from what I heard today from all of you, I think some of the patients with MOG have experienced meningitis-like attacks. So it's nice to hear that, and I'm glad we could kind of look into that further. I also want to say that I've just been very inspired by all of you today, hearing your stories. I think maybe what I'd like to say is a lot of the research I do and we do here at Mayo Clinic is very much inspired by the stories we hear from patients. We come into the clinic as clinicians first, I think, all of us here, and then we hear your stories and we get asked questions that we often don't know the answer to, and that leads us back into the lab to try and answer those questions. So a lot of our research here is really inspired and driven by you guys, and I want to thank you for that. I'm happy to answer any and all questions about symptom management. I want to also preface that by saying that, as many of you have already commented on, MOG is a relatively new disease, especially compared to something like multiple sclerosis. So we don't have a lot of data yet about symptom management in MOG. A lot of what we do know is extrapolated from our MS patients. But I'll try my best to answer those questions for you. And I also do want to hear about your personal experiences with the various symptoms that you've had to deal with and to manage. And maybe if there are certain things we should be looking at from a research perspective, I'd love to hear about that, because we are very interested in becoming more and more interested in quality of life for patients with MOG. And hearing from you guys will help to really inspire the next research projects that we do when it comes to symptom management. Thanks.
You want questions now?
Should I kind of maybe give a little bit of a talk? Okay, sure.
Go ahead.
Okay, well, I think maybe what we can start by doing is I can tell you a little bit about how I think about MOG when it comes to symptom management. Obviously, I didn't prepare anything today, so I'm going to kind of speak off the cuff here. But as you heard in the morning lectures today, I think the speakers did a really nice job of dividing MOG symptoms into kind of how we evaluate the nervous system when we're seeing a patient with MOG. So, the three main areas that I think about when I'm thinking about symptoms are the optic nerve, which is most commonly affected in patients with MOG, the brain, and the spinal cord. I think those are the three main areas that are affected by MOG, and that's where a lot of these symptoms come from. So when I think about the optic nerve, obviously optic neuritis is the type of attack that we see, which is inflammation of the optic nerve. And this is very common. Some studies are reporting between 50 to 90% of patients with MOG have had at least one attack of optic neuritis in their lifetime. So this is a symptom that we hear about all the time. And while visual recovery can be good, there are a lot of things that play a role in that. One is age. So the younger you are, the more likely you are to recover from optic neuritis. As you get older, the recovery slows down, partly due to less effective remyelination. The other thing is the amount of relapses that someone might have. So, the more optic neuritis attacks that you have, the more likely you are to have long-term visual deficits, which obviously can be highly impairing. So that's kind of how I think about optic neuritis. Now, when we talk about treatment, obviously, well, maybe I'll save that for the end, and we can talk about treatment for all the various attacks. But so that's optic neuritis. And then when I think about the brain, the main symptoms I think about, and please feel free to add because I may miss some symptoms. Fatigue, very common in MOG. About 70% of patients report some form of fatigue. Obviously, this can hugely impact quality of life and daily activity and productivity. Mood and psychiatric disturbance. About 40% of patients report mood and psychiatric disturbance, and the primary issues there would be depression and anxiety. I think up to almost 20% report severe depression or anxiety, and oftentimes we think this is secondary to the disease, so maybe not primarily driven by the attack itself, but the recovery from the attack and the disability that's left from the attack. But like I said, there's still a lot to learn about this. Fortunately, we have colleagues here who are looking into this more to try and understand, is it just a secondary phenomenon, or is there an underlying neuropathological mechanism that's contributing to psychiatric disturbance in MOG? And then cognition, many of you mentioned that during our morning talks. About 20% of patients experience cognitive issues. We think this is primarily driven by inflammation of the deep gray structures of the brain, like the thalamus, for example. And this is what we also see with patients with multiple sclerosis, although the underlying mechanisms are different. We do tend to see a lot of cognitive impairment in patients who have ADEM or ADEM, and that tends to drive a lot of the cognitive issues. And similarly to optic neuritis, children tend to recover better from cognitive deficits caused by MOG, whereas adults may have more pervasive and long-term cognitive deficits. And then the last kind of major symptom I think of when it comes to the brain is seizures, which do occur most often in the form of our cortical encephalitis attack phenotype of MOG, but can occur with ADEM as well. When it comes to seizures, they're typically what we call acute symptomatic seizures, which means that the seizures are really occurring in the setting of the attack. And as the inflammation is reduced with treatment such as steroids, most patients don't tend to develop a kind of chronic form of seizure disorder like epilepsy, although it certainly can happen in patients. We have a really good multidisciplinary team here at Mayo, and we often involve our epileptologists when there are patients with concerns for seizure disorder. And then motor deficits can occur with attacks in the brain, although it's much more common that those motor deficits would occur from a spinal cord issue. And Dr. Thakel-Waboon mentioned that earlier, and I think that's important, that it can be caused by both. Usually when it's caused by an attack of the brain, you get symptoms on one side of your body, whereas with a spinal cord attack, you tend to get symptoms on both sides of the body, although you certainly can get symptoms on one side of the body with a spinal cord attack as well. And that's why, as neurologists, we are very interested in trying to localize the lesion in the clinic, but at the end of the day, it's helpful to have some of our more advanced techniques for diagnostics, and that includes MRI of the brain and spine to better understand where that inflammation is occurring. So that's the optic nerve in the brain, and then I think the last area that I think about is the spinal cord. Now, we've talked about motor deficits. It affects about 30% of patients can have kind of constant motor deficits that prolong past the acute attack and require physical rehabilitation for recovery. The other major symptoms I think about from spinal cord attacks would include spasticity, pain. Pain is a huge factor, right? And spinal cord disease really drives neuropathic pain in patients with MOG. And finally, I would say kind of bladder issues. Now, whether that's what we call a neurogenic or spastic bladder, and so patients may have symptoms of, urgency, frequency, urinary incontinence, or it could be that the bladder just isn't contracting very well, and so you get kind of bladder outflow issues, so patients just aren't able to get the urine out. And so it's important to diagnose what the urinary problem is in order to treat it adequately, right? Because depending on the problem, the treatment is different. And so we're very quick here at Mayo Clinic to involve our urologists who often perform urodynamic studies to understand what the problem is with the bladder so that we can treat it more appropriately. And then there is also certainly issues with fecal incontinence and constipation, which is maybe something that we don't ask our patients about as much, but we really should. It is also a pervasive symptom in this disease. So that kind of covers how I think about symptoms. Does anyone want to add a symptom that maybe I didn't mention? And I'm sorry if I didn't. Yes, please. Oh, he'll grab a mic for you there.
Are you seeing in Can you hear me? Okay.
Yes.
Are you seeing in patients any kind of frequency of headaches? My mother didn't get the kind of attack on her spinal cord, but more her brain and the optic. And she already had previous eye issues. She got treated right away, but she's having kind of frequency of headaches, and that haven't really dissipated or really gone away, but just, kind of flare up here and there. So I don't know if that's a common, symptom.
Thanks. Yeah, that's a really good question. Headache is complex in general for neurologists to understand. When I think about headache and MOG, in the acute relapse attack, you certainly can have headache, and we do see that a lot. So patients with optic neuritis can present with what we call retroorbital pain, and that can manifest as headache for many patients. And then when we think about attack phenotypes like meningitis as well as cortical encephalitis, both of those can present with headache. And, it's interesting. I was mentioning earlier about this project I did with Dr. Flanagan looking at meningitis attacks in MOG, and many patients, I think about 90% of our cohort presented with headache. And the majority of patients were not initially diagnosed with MOG. Now, obviously, part of that is just due to the lack of awareness of this disease, but also because we don't typically think of headache as a symptom that would be associated with a neuroinflammatory disease. So I think it's really important when we're thinking about the acute attack or the sudden onset attack of MOG that we really do think about headache as an important potentially important sign of a MOG relapse. Now, of course, headache is a very prevalent symptom for many people, and not just for patients with MOG. So obviously we need to better understand, is the headache related to inflammation in the brain, or is it secondary to something else? But I just want to stress that I do think headache is an under-recognized symptom of a MOG attack in a lot of cases. So that's important. Now, in terms of kind of chronic headache, I think that's a little bit more difficult to answer. I will say that I think of headache much like I think of epilepsy, where when you might have the acute seizure, the initial seizure or the initial headache due to the attack, but even after the inflammation goes away, you can essentially have recurrence of these symptoms over time, especially when your body is under stress. So I do think that there is a component of that may contribute to chronic headache. And then I also think that the studies aren't clear on this. What I see in a lot of my MS patients is a lot of them have migraine headaches that are kind of comorbid with their MS. And rarely is the MS the driver of that, but it is very interesting that patients with MS tend to report migraine as well. And I do wonder if, perhaps there is a component of that in MOG. I haven't seen enough MOG patients to really note that, but I think when I think about headache, one, we should make sure that the patient is not having a new relapse or attack of MOG. And then if they're not, we should really think about symptomatic management of that headache. There's a lot of great treatments out there now for treating chronic headaches. So we often involve our headache specialists here at Mayo Clinic. Yeah, go ahead.
My question is about intercostal neuralgia. I haven't heard any of the doctors talk about it, but I was sitting at a table last night with 2 other women who have it, and I have it.
Great, yeah. Well, no, not great question. Sorry. Truthfully, I don't know about an association between MOG and intercostal neuralgia. There have been some recent studies looking at whether, we typically think of MOG as a disease that affects the central nervous system. When we talk about the central nervous system, we're meaning the optic nerve, the brain, and the spinal cord. For most of the period of time that we've recognized this disease, we haven't thought that it affects the peripheral nervous system, meaning anything beyond the spinal cord. There are now some studies that have been looking into the peripheral nervous system and whether that could be affected by MOG. I'm not an expert on these studies, to be honest. A lot of my practice involves the central nervous system, so I don't see as much patients, who have neuromuscular issues. But from what I've read, it seems like it is possible that MOG could affect the peripheral nervous system. I think more evidence is needed before we can really say that for sure. But some of the early papers that have come out are certainly interesting and raising questions. And while I haven't heard about that association with intercostal neuralgia, it would be an interesting question to study, actually, especially if you're seeing it among other patients who are also reporting it. And this is kind of why I like these Q&A sessions, because these are questions that are, fairly easy to answer in the research world. We just need to know that patients are experiencing that. So thank you for bringing attention to that.
I was wondering if you could maybe comment on blood pressure increase as a symptom. We have been told sometimes for my son that that's due to MOG, where the inflammation is, and other times it's hard to distinguish because it could be because of steroids or IVIG. So just wondering if you had any thoughts on that.
Sure, great question. So I'll be very transparent. I am not aware of an association between blood pressure and MOG. When I hear about, I think first off, a very astute point about the steroids. So we do know that obviously when someone is coming in with a MOG attack, they're getting very, very high doses of steroids to try and calm down that inflammation, and that is certainly going to affect blood pressure. It can cause labile blood pressure and high blood pressure for sure. When I hear about blood pressure issues in general, I kind of think about the autonomic nervous system. That is part of the peripheral nervous system primarily that drives heart rate and blood pressure and things of that nature. Like I mentioned before, there is this idea, this concept that could MOG be affecting the peripheral nervous system? It's certainly possible. The studies that have looked at it haven't looked at the autonomic nervous system. So as of right now, I'm not aware of any link between the autonomic nervous system and MOG, but that would be a very fascinating area to look at. So thank you for raising that point.
Our son had an attack 2 weeks ago, so he just got diagnosed. But for like the 6 months prior to that, he was throwing up a lot, and he was having a lot of daytime sleeping, and he was having he would just, peeing accidents. He's 21. So I'm wondering, were some of those things maybe precursors to the attack? Then he had bilateral optic neuritis, black in both eyes. He's in a cave. So I'm wondering, are those things maybe precursors? And since he just had his first attack, if those things start to happen again, should we,
Yeah.
Just wondering about that. Thank you.
Sure. Thanks for that question. I think you're observing kind of an interesting concept in MOG that I think is becoming more recognized, which is there seems to be a bit of a lag between when the symptoms occur and when we actually start to see changes on brain MRI. Dr. Casaguera has done some good research on the radiologic lag in MOG. And when we looked at our study, meningitis and MOG, what I was finding were a lot of patients were complaining of meningitis-like symptoms, so headache, nausea, vomiting, photophobia, so sensitivity to light, and neck pain. And they would come into the emergency department and undergo an MRI of the brain, and the MRI of the brain would be normal. So, but interestingly, these patients, they would be sent home, and then they would end up coming back, a week later with optic neuritis or transverse myelitis. So what we are maybe starting to think about MOG is there is this radiologic lag that's occurring as potentially the immune system is ramping up, the inflammatory cells are coming into the central nervous system, and we may not see them right away on brain MRI, but they're already affecting the central nervous system. Interestingly, Dr. Flanagan had mentioned in his talk about microglia PET, and even mentioning that he's seeing changes in microglia activity. These are inflammatory cells that likely play a role in the pathogenesis of MOG. He's already seeing that on PET even before the MRI shows anything. And that kind of nicely correlates with Dr. Casaguera's studies looking at radiologic lag in MOG and the study that we did looking at meningitis in MOG. And we do think that meningitis and MOG really is just radiologic lag. It just hasn't appeared on MRI yet, but it's about to. So, I think it's good to be cautious, and especially if you're recognizing a symptom pattern in a loved one, it's always okay to seek medical attention and see if something might be going on. And I think from our standpoint, we need to be more aware that, the MRIs might be normal initially. And if we're not sure, it might be worthwhile to do some other testing, possibly a spinal tap to look for inflammation and, intrathecal inflammation. So, yeah, it's a great question.
Hello. Oh, that's loud. Sorry, folks. I just had a question, like with our son too. A big thing for us is a flare-up is not being able to urinate. So that is like a red flag for us. Like, okay, something's happening. But when I was listening to you a few minutes ago, like we've never met with a urologist. I say that right, babe? Yeah. See the constant judging or looking at me. But is that something we should look at? Because, I mean, I know my son thoroughly enjoys the catheter. But that's what happens to him a lot, because he did have a lot of lesions on his spine and stuff like that. So I didn't know if that's something we should, because we've never met with one. No one, they've never talked about it. They just scan his bladder and get a catheter out until he's able to go on his own again.
Yeah, no, fantastic question. Thanks for that. The easy answer is definitely. Now that's easier said than done. I realize that, depending on where we live and our access to resources, we may not always be able to access a urologist when we want to. But I personally believe, and it's not because my father is a urologist, but that urologists can really offer a lot when we're treating patients with myelitis or transverse myelitis and neurogenic bladder. Like I mentioned earlier, I think intermittent catheterization is certainly a mainstay, especially with outflow problems. But trying to really fully understand the issue and seeing whether there are sort of lifestyle interventions, bladder exercises, and oral medications that can help to complement this. Now, and that's more in kind of the chronic, kind of long-term outlook, but any abrupt onset, inability to urinate really should be looked at closely as a potential attack of myelitis. So that's trying to answer both sides of that question. But yeah, the easy answer is yes. And when you come to see us at Mayo Clinic, we almost always involve our urologists. We really want to clarify what the problem is. Just like it's important to clarify the diagnosis in MOG and to differentiate it from MS and NMOSD, it's also important to understand how MOG is affecting the body. And part of that is understanding how it affects the urinary or urogenital system. One symptom I also forgot to mention is sexual dysfunction, which is also a fairly prevalent issue with myelitis, and urologists are very well equipped to handle that symptom as well. So apologies for not mentioning that earlier, but they've got a ton of knowledge. They've got a lot of fancy techniques where they can really find out what's going on with the bladder and how can we best improve quality of life. Okay. All right. Yes, please reach out. I think my email should be out there. Cool. All right, thanks.